So question number 2, what is the definition of recurrent UTIs? A, 1 episode per month, B, 2 episodes in 6 months, or C, 3 episodes in a year. I think you'd be right if you said all 3, all of the above, if A was for a minimum of 6 months. It's not that many, 3 a year. I know patients who have sometimes 3 a month, and it should be a cue for reevaluation. Why is this important? It's, UTIs are the #1 reason for rehospitalizations. And because people have neurogenic bladders, they are at risk for UTIs. Again, it's a secondary health complication and adds to the morbidity and mortality of spinal cord injury. Along with neurogenic bladder, a lot of people use catheters for bladder management, so that puts them at risk. Diagnosing a UTI, it's not just the urinalysis, cultures and sensitivities. We really want to see clinically what's happening. Fevers and chills, classic, but people just don't present the same way. They don't have the dysuria, they don't have the cramping. What they will show up with is my spasms are worse, or I'm getting AD and I can't figure out why. I'm not constipated. My bladder, I'm having bypassing and I never used to have, urinary incontinence. Or simply malaise or just malodor. I've had somebody had shortness of breath and we were working them up for pneumonia, but it was really a UTI. And then this goes hand in hand. If you can please get a urinalysis, culture and sensitivity, because we look at pyuria, bacteriuria, and cultures. And I'll go over an example of a recent UA. Question number 3, what is the best way to obtain a urine sample when someone has a Foley catheter? Do you get it from the leg bag here? Do you get it from disconnect the leg bag and the Foley and get the sample there? Or do you need to remove the existing Foley and put in a new Foley catheter and get it from the new catheter? And I hope everyone is thinking C, getting it from a new catheter. But you would have to understand that this Foley catheter, whether it's been in for 1 week or 1 month, there's a ton of bacteria that can grow even from this lumen here, much less the bag that's been there for a long time. So what we really want to know is what bacteria is growing in the bladder. I think we have to really consider how is this done in the community, and I don't have an answer for that because it's dependent on when the community, the home care nurse goes in to change their indwelling catheter is when they can get the new sample. But if a UTI creeps up, how do they navigate that? Okay, so this is a real urinalysis from a patient recently. You could see April 17th, the urinalysis was essentially normal or negative. And then April 30th, it was positive, and I'll go down with you what I tend to look at. Specific gravity is a really good number. In my mind, I think of 1015. 1.015 is the normal. So this is pretty close. And you could see back in April 17th, he was pretty diluted. He's a good water drinker. And then leukocyte esterase. So this is the pyuria. It's moderate. It could be large at times. And then nitrites, bacterial breakdown is positive. I also look at pH at 8. That means it's basic, alkalinic, and that's due to urease producing organisms such as Proteus. And then I look at, and you can see hemoglobin is large because, again, the irritation to the bladder wall from the bacteria. So this is one component that flags, yes, there is pyuria, and there is an immune response in the urine. So if he's stable, I tend to wait for the culture results. But if, he's spiking a fever, spasms are, unbearable, I'll start empiric treatment right away. If not, we wait to see the culture. And what the culture, it'll come out 48 hours after the urinalysis. But this is important. This is what I look at is the organism, and it should be greater than 100 million, and this is Klebsiella, and then organism 2 is 80 million of E. coli. The sensitivities, they break it down to organism 1 and 2, and you could see Amox is both organisms are sensitive, ampicillin, it's resistant, and then Cipro, sensitive and resistant, Septra, sensitive and resistant. So clearly, we would then choose Amox and Clav, which is a good first-line empiric antibiotic for most folks. And then I would treat for 7 days, not 3, not 5, not 14. So if left untreated, of course, people can manifest autonomic dysreflexia if they are at risk for it. Sepsis and bacteremia is not uncommon. And then other complications, such as even skin breakdown, because now they're incontinent of urine. So the key recommendations is to really maintain a level of suspicion for a UTI, because people just don't present the same as those with non-SCI symptoms. For people with spinal cord injury, they can have autonomic dysreflexia. This is the headache, sweating, flushing phenomenon, increased muscle spasms. And then, like I said, respiratory, they can become short of breath just because I think they have an active infection. GU, urinary bypassing, malodor, general fatigue, fevers and chills, and then GI with nausea and vomiting. Basically, if your spinal cord patient presents to you with any kind of concern, I would rule out UTI. And then the SCI project, I hope everyone is familiar with this, has a really good algorithm of everything we've covered today.